Martin, who's going to talk to us about the paediatric medication safety thermometer that's being used in Birmingham, which I think will be really informative for all of us, and hopefully something we can all think about how we might be able to get involved in this project. So just to introduce myself very quickly, I'm Alice Rouchet. I'm a general paediatric consultant at the Evelina, but also one of the senior users for the MedsIQ programme, along with Jane Ronicles, who I'll hand over to you to introduce yourself.
Hi, I'm Jane. I'm a general paediatrician at the Royal Free Hospital and also one of the senior clinical users.
And then we have with us Kasia. Kasia, do you want to introduce yourself?
Hi everyone, my name is Kasia Muszyńska and I'm the project manager for MedsIQ at the Royal College of Pediatrics and Child Health.
And it's Kasia who keeps everything afloat, which is brilliant. And then Jeff, I'm going to leave you till last because you can introduce yourself just before you start. But I can see, so we've got Steve. Do you want to quickly introduce yourself?
Hi, yeah, Steve Tomlin, consultant pharmacist for Children's Services, also at the Evelina Children's, and I think sort of lead pharmacist within MedsIQ review, I think.
Yeah, definitely. And then on the, I'm going to go through people I can see on the attendee list, and then we can, if there's anybody else lurking, do please say hello. So I've got Eve Blanchard, but Eve, you have a line through your, oh, I can see you've put a message up saying your microphone doesn't seem to be working, but you can hear us all fine, and you're a paediatric registrar from West Yorkshire. Brilliant. Hello, Eve. It's good to know that you're here. And same for Prashant, who has sent us a message to say that he is with us as well, but also has some microphone problems. So I will do my very best, guys, to keep an eye on your chat screen. So please do feel that you can speak to us through the chat service, and I'll try and keep up with those. And equally, if anybody else spots something coming up that I haven't seen, do please raise it to my attention.
Well, guys, if you have got mobile reception, sorry, I'm saying if you have got mobile reception, you can dial in on a different number, but then you don't see the screen. So it's a trade-off. If you'd rather talk, you can dial in on the mobile.
Or you can simultaneously do both, so you can have it on your screen and then phone in as well on your phone, and then that will make us feel that we have double the number of participants. But it enables you to see the slides and also talk. So that's Prashant and Eve, and then we've also got Eva Zizkova, who also has a line through her. Oh, hang on, there we go. This is Eva, who says she also doesn't have a microphone, but can hear us and can't speak, who's a quality improvement nurse from the Brompton Hospital. Brilliant. Hello, welcome, Eva. Is there anybody else on the call whose name I haven't mentioned? Speak now if you're out there.
Rhian Isaac, Birmingham Children's.
Oh, hello. What was your name?
Hello. Rhian Isaac, Birmingham Children's Hospital.
Brilliant. Oh, welcome.
Thank you.
Fabulous. In which case, I think in the interest of time, because what we always find is we start a bit slowly and then we have a mad rush to get everything in the hour, and we're keen to finish on time today. So I will hand over to Jeff Martin to introduce the Paediatric Medication Safety Thermometer.
Okay, thank you very much. Can everybody hear me okay?
Yes.
Yep.
Yeah. Okay, great. So my name is Jeff Martin. I'm one of the consultants on the intensive care unit here at Birmingham Children's, and also one of the associate chief medical officers with responsibility for safety and quality, and more recently taken on responsibility for the medicine safety officer as well. So what I've been asked to do is really give you a run through the work that we've been doing with the Paediatric Medication Safety Thermometer, and Rhian, who's just joined us, has been working with me on this. So I basically just got a few slides to go through and tell you the story of what we've been doing and where we're at now, and if you've got any questions then please just ask.
Great, thank you.
Okay, so I'll kind of assume nothing, and so some of this, if you know, apologies, but just wanted to give you or people a bit of background in terms of the safety thermometer work that's been going on in the NHS. And safety thermometers have been around for a few years now, and the idea is that basically they provide a temperature check, if you like, hence the name, of harm that can be used alongside other measures within the NHS with the aim of managing down that harm over a period of time. They were commissioned from Halo, based in Salford, by NHS England, like I say, a number of years ago. And the first safety thermometer back in 2012, which is now termed the Safety Thermometer Classic, was the first one that went live nationally. And that one was started looking at 4 particular harms in adults. So that was falls, venous thromboembolism, urinary catheter-associated UTIs, and pressure ulcers. And the idea was that on one day a month there would be a point prevalence collection of data of all inpatients in all institutions. To start with, I think it was incentivised through a national sequin, but data collection is still ongoing now after the sequin's obviously long gone. And so this is a slide pulled from Halo, really, which really kind of shows what the idea was. So I don't know if you can see my mouse moving on the screen or not.
Yeah.
Yep. Anyway, yep. Okay. So it's a graph here on the right, which shows how the safety thermometer is supposed to work. So say, for example, you were looking at pressure ulcers and you measured kind of 9 in January. Over a period of time, you would, by interventions that you put into place, you would hopefully see that number drop. And that was the idea behind all of the 4 metrics. And there were 4 metrics that were associated with harm. So that was the first safety thermometer that was developed. We worked with BCH with a number of other major children's hospitals in developing a paediatric version of that, along with Halo. And that basically led on to what they call a suite of safety thermometers, which included, more recently, a medication safety thermometer as well. So there's now one for mental health and one for maternity, as well as the children's and young people's safety thermometer. The medication safety thermometer was generally aimed at adults. There were aspects of it that weren't suitable for children. And so in consultation with Halo, we basically have developed a paediatric or a more paediatric appropriate medication safety thermometer based on the adult version. And we've been piloting that here at BCH. These are the design principles that the safety thermometer is supposed to follow, and in particular we were really quite keen that we keep the data collection time down as much as we could. So the safety thermometers aren't supposed to collect every possible data that you can. They're supposed to be done quickly and give you something that you can feed back quickly to the staff on the ward to make changes. So this is what the adult safety thermometer the medication safety thermometer looked at. There's some kind of generic data about the patient's gender, age, how many medicines they were on to give you some idea of a denominator, whether allergy status was documented, whether medicines reconciliation had been done, and whether there was any evidence of omitted medicines in the previous 24 hours to the data collection point. And if so, then were the reasons documented as to why the drug was omitted. Also, whether the patient was on any high-risk medicines, those being opioids, anticoagulants, insulin or sedatives. And if the answer to that question was yes, then you would then proceed on to complete part 2, and that would basically look for triggers of potential harm from those high-risk drugs. And if a trigger was found, then you would proceed to a part 3, and that was where there would be a multidisciplinary discussion to determine if harm actually had occurred or not. So part 2 was to look for a trigger for potential harm, and part 3 was to determine if harm had actually occurred. So these are the changes that we made. So we added in weight to that because we felt that obviously weight is very important for calculating paediatric drugs, and that should always be on the drug chart. We removed sedatives as one of our high-risk medicines, and the reason for that is this was mainly around the use of benzodiazepines. And on the wards, we don't tend to use that very much. We use a lot of it on intensive care, but that's with the deliberate aim of sedating patients and sometimes reducing their respiratory rate. That's what we want. So we took that out of there, but we added in a prescription for a wrong dose. So we know that one of the big problems we have in paediatrics is getting the dose wrong. We also had to change a number of the triggers for the high-risk medicines and make them age appropriate. With opioids, for example, the triggers are all to do with the respiratory rate. So you might find that the patient's respiratory rate is reduced if you've given an overdose, for example. But obviously, with the respiratory rate varying in children, there had to be age-appropriate bands for that. And then also, we had to, of course, add in triggers for a wrong dose as well. So that was our data collection form. We've had some issues along the way. We've had some support from Halo in terms of the ideas, but we've not had any IT support to do this, so we've had to try and do that all within house at the moment. Our data collection tool, so it's paper-based still, and we have a system where that's inputted into an electronic database. We don't currently have an electronic tool that we can use on a tablet to use at the bedside, which is would be the ideal. So that's because the electronic interface isn't in the format currently that can be used on as a tablet. So we have this quite lengthy system whereby we're collecting it on data, that then gets taken off-site and inputted by a data clerk into the database, and that obviously adds quite a bit of delay into the system. And we've had, because of that kind of protracted method, there's been a few data collection and quality issues that have therefore been difficult to manage that we've been trying to work through. And then we've had some questions misunderstood by the people collecting the data, which obviously doesn't help. So I'll kind of talk a bit more about those as I go through and we look at some of the results. So other concerns that we've had as we've been going along is to do with about how many patients we're actually collecting the data on. So our aim was ultimately to collect it on all inpatients. And I'll talk about that a bit more as well. Other questions that we've asked as we've gone along are whether we've got the questions regarding harm correct. Where have we been setting the triggers, for example, and are we picking up all harms that are potentially occurring, and whether we should be using different questions or even looking at different medicines as well. And also, how can we get the ward nurses more involved in the data collection? So currently the data collection is largely done by the ward pharmacist. The idea behind this was to get a ward pharmacist and a senior ward nurse to collect the data together so that the ward nurse could be involved in that process, and if errors or problems were picked up, they could look at dealing with that there and then. But you can imagine getting the two people to coordinate that has been quite challenging, and I'm not really quite sure that we've achieved that as yet. And then the final question really is, we've got a lot of information already from our incident reporting data, and the question is the safety thermometer telling us anything we don't know already? And I'll come back to that. So looking at the data, this is just a basic bar chart which shows the number of forms that we've been collecting each month, and you can see that that's quite variable and goes up and down. We had a particular issue around this time that I've highlighted here, where we felt that there were a number of wards that for some reason hadn't collected data, but it's been reasonably consistent since then. Towards kind of August 16 we had a little bit of a worry, but this is the bar chart below is with a line added in which gives us the number of inpatients in an inpatient bed at midday on the day that the data is collected. And so that you can see there are kind of natural ups and downs in that, and there's a dip in that here which corresponds to the dip that you see in the bar chart as well. So we can see that we're currently collecting data on around 70 to 75% of patients, inpatients. We're not really quite sure why we're not getting up to 100%, and I'm sure there's a number of reasons behind that, but it seems to be fairly consistently between 70 and 75%. This is looking at patients with documented allergy status, and that's been a bit up and down. It's a period here that was a little bit lower, but it's gone up in the last data point that I've got, which is February. But you can see generally it's pretty good. It's above 96, 97% most of the time. With recorded weight, again, it's generally quite a high level. It's generally sitting above 96%. But it does tell us that there are still a few % of patients where we're not documenting the allergy status or the weight, which really should be there in 100% of cases. Medicines reconciliation is interesting, and it's an area that we knew that we had a problem with already. And initially, when we were collecting the data, we looked at our figures collecting medicines reconciliation within 24 hours, which is based on the adult standard. Although, from what I understand, there's no set standard for children at the moment. This period prior to August 16 is lower. That you can obviously see the data here is lower, but it became apparent to us that this data wasn't accurate, that the people collecting the data weren't understanding the question, and we had to do quite a bit of work around that. And I think this was probably a mixture of people collecting the data accurately and other people thinking that we were asking about whether medicines reconciliation had occurred at all. We think that from August 16 the data is more reliable. And also from that point, on the second graph, you can see that we've started collecting data looking at whether medicines reconciliation has occurred within 72 hours. You can see that since August 16, there's a general downward trend in the number of patients who haven't had medicines reconciliation completed within those two timeframes. And that's really without any specific intervention at the moment, other than making it making the staff more aware that this is data that we're collecting and the importance of it. We're doing quite a bit of work around understanding what the barriers are behind this issue at the moment, and we will be obviously doing a piece of work around that to try and improve the numbers. And with the safety thermometer setup as it is, we'll be able to track those interventions and see what difference that makes. This shows a proportion of patients with the wrong dose prescribed. Figures generally sitting anywhere between 2 and 6%, so probably about 1 in every 20 patients or 1 in every 20 prescriptions there's a wrong dose prescribed. And this is the proportion of patients with an omitted dose within the last 24 hours. And there's a little bit of a breakdown under that. You can see that the high-risk drugs, so insulin and opioids and anticoagulants, generally it's quite rare to get an omitted dose. More doses of anti-infective drugs omitted, but most of them fall into other categories, which is the grey line. And we're able to dig down into that in a bit more detail. So this graph tells us whether there was a valid clinical reason for the omission or not. So it's the blue bits of this graph that we're more interested in. So a valid clinical reason might be, for example, a patient taking captopril, but the blood pressure is a bit low, and so the captopril is omitted. That would be a valid clinical reason for omitting the drug. If another reason is given, then we can break that down further as well. And there's a whole number of other reasons why the medicine might be omitted. What we've been trying to concentrate on more recently is the red parts of the graph, so when it's just not documented why the omissions occurred. And there shouldn't be any red on the graph, really. If the omission has occurred, then it should always be documented whether there's a good reason for the omission or not. And so this is just a line graph just showing that, just kind of tracking that, the not documented reason. We've had quite a low number of patients who've triggered on the safety thermometers we're currently using it, and we've only had one patient where the patient triggered as a potential harm, where on review it was actually felt that harm had definitely occurred. And this was a patient on ITU who'd been started on a heparin infusion prophylactically. They were a patient who had cardiac surgery and they had a shunt in place. And all these patients, they started on 10 units per kilo hour of heparin to prevent shunt occlusion. And this patient had significant bleeding, requiring a blood transfusion following that. That was recognised, the heparin was stopped for a period of time and then restarted without any further problems. So it was felt the harm was minor and resolved quickly. It wasn't felt to be a preventable harm, as it felt that the heparin was necessary as prophylaxis for the shunts. And in fact, if we don't use heparin and we get shunt occlusion, then that can be life-threatening for the patient. So we didn't feel there was any action that needed to be taken following that. So following that kind of information, we kind of questioned, well, have we got the trigger set correctly if the harm that it's picking up is so low? So we looked back at our incident reporting system, and this was over a period of 12 months. there have been just over 5,000 incidents reported during that time. Medication incidents accounted for just over 1,000, so about 20% of cases. And in 9% of those, the reporter who completed the incident form reported harm occurring, so quite a low level. And in 99% of those, the harm was felt to be minor, with only 1% being reported as it leading to moderate or semi-permanent harm. Now, of those medication incidents where there was reported harm, we looked at those more closely and we assigned them a MERT classification. And I don't know whether people are familiar with the MERT system, and if not, I just pulled this up here. This is a system used in the States to try and identify, firstly, whether errors occurred in the incident, and if so, whether harm has occurred or not. And you can see as you go around the pie chart, it has more. The incident has more significance. So A, there's no error that's occurred. B, an error has occurred, but it hasn't reached the patient. So that might be, for example, a prescription error that's picked up by the nurse and the drug never gets given. Sorry. C, the error reaches the patient, but there wasn't any harm. And D, the error reaches the patient, and you've had to do something to determine whether harm has occurred or not. So maybe you've had to do some blood pressure monitoring or check a blood level or something like that to determine whether harm might have occurred. And it's only when you move above E that you say that harm has occurred, and then the severity of the harm increases as you move through all the way round through to I, where the patient died. I don't know why that segment's green if the patient's died, but that's the way it is. So we reviewed those 94 and assigned them a MERT classification, and we found that only 27 out of the 94 actually had a MERT classification of E or more. So in the remainder, we determined that harm hadn't actually occurred despite the person reporting the incident saying that it had. And what we think is that often the reporter saw that the drug error had reached the patient, and therefore they determined that harm had occurred, whereas that wasn't necessarily the case. So in only 29% of those 94 where harm was reported did actually harm occur. So we think that the true percentage of medication incidents where actually harm is occurring is more likely to be around 2.5%. Now you could argue that that in the remainder, so we only looked at 94 that had the reported harm, so there were about 900, over 900 more where the reporter hadn't initially reported harm, so some of those actually harm could have occurred. So we looked at more recent data. This is over the last 12 months up to December 16, and at this point, using MERT to classify our incidents was much more common, and we were classifying them in almost 3/4 of cases. And only in 17 of those 797 did harm occur, so they had a MERT score greater than E. So this was not retrospective review, but review as it was as the incidents were being investigated. So again, indicating that actually the level of harm that we're seeing from medication incidents is actually quite low. So that kind of fitted in with what we were seeing from the safety thermometer, in that if not much harm is actually occurring, we're unlikely to pick up much harm through the safety thermometer, where we're just doing spot data collection once a month. So we felt that the triggers probably were set correctly, but harm from medication error in children is actually quite a rare phenomenon. So then we got to thinking, well, okay, if it's not really telling us that patients are being harmed and we're not identifying much harm, then is it telling us anything we don't already know? So the answer is yes and no. We knew that we've got a problem with medicines reconciliation, and we know from medication incident reporting that the vast majority of medication incidents that are reported are to do with omitted medicines, so that's flagged up as a significant issue. And we know that dosing errors are common in paediatrics, so some of that we do already know, but it has helped us significantly in showing us, okay, well, what's the extent of the problem that we have with medicine reconciliation? How many patients aren't, isn't that being done, and the ability to track that over time. It's given us baseline data on omitted medicines and wrong dose prescriptions, and we can track those with improvement projects that we put into place. We've recently launched e-prescribing on our liver unit, and that will be rolled out across the hospital, so we'll be able to see what impact that has on things like omitted doses or wrong doses. And it's also given us the additional assurance that there is a low level of harm occurring that we thought was probably occurring, it was probably the case from our medication incident reporting, but we couldn't be sure. But now we have a more objective measure that seems to confirm that. And it's also helped us to put our incidents into perspective as well. So looking at the denominator data, it's helped us to put our other data into context. So when the medication safety thermometer data is collected, we collect the number of regular medicines that the patient is on that day. So we can extrapolate that data to give us a rough estimate of how many medicines we're administering. So from the data from 2016, we can say that on average about 1,200 regular medicines are prescribed each day, and that's looking at about 265 patients each day. So some of those will be given once a day, and some of those may be given up to 4 times a day. If we just guess on average that is around twice daily administration, that gives us about 875,000 drug doses administered per year. And then, of course, if we think about, well, the one-off doses, the PRN doses, infusions, what goes on in theatres and outpatients, we know that we're giving over 1 million doses or drug administration events each year. And so if we compare that to the fact that we've had just over 1,000 reported incidents, 73 with a significant risk score, 17 that we think have caused harm, and we've actually only had 1 significant or serious incident requiring investigation during that time, it kind of puts everything into perspective for us, really. It's not to say that obviously there aren't things to improve on, but it helps us give some context to our data. So we feel it's basically is providing us with this temperature check that we can use alongside other measures. So we've still got our incident reporting system, and this is just one other measure that we can use to look at how we're doing in terms of medicine administration and whether we're causing harm or not. So thinking about, for us, where we're going at the moment, we really want to develop an electronic tablet-based data collection tool to iron out a lot of our data collection problems. I've already mentioned that we've got our e-prescribing that will be rolled out probably over the next 12, 24 months across the trust, and we're really interested to see how that will affect our data and whether that will add in additional problems or whether it will get rid of some issues that we know we've got. And then a question really is whether other centres would be interested in using something like this. So the other safety thermometers are available nationally. Currently the paediatric medication safety thermometer isn't. And for that to work, really, there needs to be some kind of web-based portal for that, as with the other safety thermometers, and some kind of centralised database. We've had some conversations with NHS Improvement with that, and it looks as though the way that we're going to need to go is via the local patient safety collaboratives to see whether we can use those to draw the attention to the central measurement unit. But that's kind of our next step, really. That's pretty much all I've got to say. I don't know whether anybody's got any questions about what I've said or what people think.
Brilliant. Thank you so much, Jeff. That was really, really interesting. I mean, so many different topics actually covered in that, from, you know, the data collection and the interpretation and the linking in with everything. I think that's really, really interesting. So let me open out to the wider audience. Does anyone have any specific comments or questions?
Steve Tomlin here. I was at the Child Health Safety Board a couple of years back when this was first being discussed, and Halo were around the table. And one of the issues which came up was whether one of the big flags should be sort of 10 and 100 times overdoses, since they seem to be specific to peds and never seem to happen in adults. That obviously hasn't come through with this. I was just wondering what your thoughts were on that.
Yeah, I mean, we have recognised it as a specific problem, and we're actually doing another piece of work around that at the moment as well, looking at what data we can mine from our incident system. I think we decided that probably that 10 times dosing errors were, if you like, just part of the wrong dosing problem, and they were, whilst they perhaps were specific to paediatrics, they were, if you like, only a small proportion of the wrong dosing errors that we see. and we just as commonly see, 2 times dosing errors or 5 times dosing errors, or people just, getting the dose wrong for whatever reason. And so I guess we felt that it would be better to look at wrong doses in totality rather than isolating out those 10 times dosing errors, which is why we went for that measure.
Okay, thank you. I mean, this is obviously a time-consuming task in some ways, and your outcomes would suggest that in some ways you don't gain that much additional data to work from. But do you see this as a tool which sort of emphasizes safety, and therefore it puts the safety agenda higher up the agenda, and therefore has a role in that respect rather than the actual data that it produces?
I mean, I think that's one of the questions that I've been toying with about, as you say, it is time consuming, and particularly because of the data collection problems we've had, trying to ensure the accuracy of the data to make sure that we're drawing the right conclusions has been challenging. And therefore, if it isn't telling us anything we don't already know, is it worth it? And I think that whilst it in some ways it doesn't tell us that the problems, it hasn't highlighted new problems for us, it has given us a more objective measure to the problems that we already knew we had. So, for example, the medicines reconciliation, we've now got data which tells us how often that is not occurring, for example. And so when we implement specific actions in reducing that problem, we'll be able to see whether those actions have made a difference. And issues with wrong dosing, for example, we will be able to see when e-prescribing comes in what the impact of that is. So, I mean, it's a bit like medication incident reporting in that the majority of incidents that we see reported are of low level of harm and a low level of risk as well. So you could argue, well, what's the point in reporting them all? And the idea is that if you report those where the risk is low and the harm is low, and you highlight people's awareness of the issues, then the idea is that you will help prevent the more significant incidents. And I guess it's that kind of level that we're working on in terms of safety. We're trying to get people to address the low-level issues with the aim that we're going to prevent that SIRI or those incidents where harm is occurring. Because the other option really is just to say, okay, well, we've now demonstrated that there isn't much harm occurring. Let's not bother doing anything about it because it's not.
Yeah.
So it is difficult because it is time consuming, but I think a lot of that will, well, some of the time involved in collecting the data and inputting it will go once we've got an electronic tool, so that will make a big difference. But I think having thought about it a lot over the past 12 months, I think it is worth collecting the data for those reasons. It will help us track our quality improvements as we go forward. I don't know if that answers your question.
Yeah, thanks very much.
It seems to me that it's much of this is about that sort of the culture of the improvement, that having the thermometer has some effects just on the team culture. I just wanted to raise, there's a couple of questions that have come up in the comments section, and actually that link to some of my own observations. So one of the questions was about whether, as well as raising awareness and looking at the data, have there been any specific interventions that have arisen because of the data you've collected? So for example, I think you alluded to some of the medicines reconciliation stuff. Has the thermometer triggered some individual improvement projects or anything like that?
So there are a number of projects that we've got ongoing. I wouldn't say that any of them have definitely, well, certainly none of them are complete. And I think, what's the best way of saying it? I think that most of them are probably still at the quite early stages. So for medicines reconciliation, what we've been working on is trying to determine what the barriers are at the moment. So we've been surveying all of our ward pharmacists to find out what training they've had and what they feel are the barriers to the medicines reconciliation occurring. So is it to do with the fact that the parents aren't on the ward when they're trying to do it? Is it to do with the amount of time that they have available to spend on the ward? Is it to do with the training that they've had, or whatever, you know, a number of other reasons. And once we've kind of analysed that, then we will be in a better position to actually, say, find, you know, make some changes. So if, for example, we find that actually training is an issue and they've not been trained, then we can then implement a training program. Or if we find that the main problem is that it's the amount of time that they're able to spend on the ward, then one of the things that we're considering is, okay, do we get them to complete a work diary so that we know what the demands on their time are, and therefore how can we prioritise medicines reconciliation in with the other work that they need to be doing. So that's the work around medicines reconciliation. We're doing a bit of work at the moment around wrong doses. So we've been looking at what the barriers are and the barriers to wrong doses reaching the patient, and then what the recovery mechanisms are when that occurs. And we found significantly that a lot of the currently a lot of the errors are picked up through the double checking process, either at the first point of drug delivery or actually later on. So it might be future administrations where the error is picked up during the double checking process. And so we know that that's an area that we kind of think is partially working. The double check process is clearly picking some of them up, but we also know that it's there's a significant proportion of dosing errors that are reaching the patient and being only picked up on subsequent administrations. So we're doing a bit of work around double checking and how truly independent that is, or whether it's just introducing confirmation bias. And then of course we've got e-prescribing, as I said, that's being launched. So that we're hoping will help tackle some of the problems around dosing errors. But you know, we're only just into that intervention at the moment to see actually whether that makes a difference. So it's only been introduced in one ward area currently.
It seems to me that.
Yeah, sorry.
I was going to say, actually, it's brilliant. Then if you've got the thermometer set up and it's kind of rolling along collecting the data, even if the data at the moment isn't massively the impetus for change, actually if you've got a big change coming up like e-prescribing, then hopefully if you think your thermometer's set at the right level, then if you introduce e-prescribing and it throws up a whole load of unexpected problems, then you should be able to pick those up and demonstrate that because you're collecting that information. So that, you know, it may be that one of the benefits of a thermometer is that it sits there waiting for you to test the system a bit.
Yes.
Just again looking at the comments, there's one about linking with the incident reporting, and I suppose that may be about whether you know, if your incident reports were suddenly throwing up real problems that hadn't been picked up in your thermometer. Have you had any problems like that, or have you been able to use your incident reports to kind of triangulate what you're collecting?
I think the issue with the safety thermometer is it just collects data on one day a month. So it in no way replaces the incident reporting system, and it gives you a different perspective on it. I think that they will tell you similar things, but in a more objective way. So an incident reporting system will only tell you what people are reporting, whereas the safety thermometer doesn't depend on what people report because we're objectively going around collecting the data. the way we set the safety thermometer up, and the way, well, it was, like I say, it was based on the adult data, but it obviously in adults, similar issues must arise. So one of the things that they wanted to look at was omitted medicines as well. So we know that from our incident reporting system that the majority of medication incidents reported are omitted medicines. And so that's clearly something that we're tracking with the safety thermometer as well. So in that way, we've deliberately set it up to tell us the same information, but from an objective viewpoint. The safety thermometer hasn't picked up anything different from our incident reporting system, but that is probably because of how it's been set up. I think we'd have to ask different questions, but then the question would be, well, what would those questions be? And we've tailored it based on our knowledge of the problems from the incident reporting system. So we'd have to be asking questions that we currently haven't identified what the problem is, which would be quite difficult, if you see what I mean.
Yeah. Brilliant, thank you. Are there any other questions from other people on the call? There's a few more in the comments, but let me give people on the call also a chance to ask.
It's Oliver Rackenby from Park from the World. It's a comment really about that. I think it is really useful, like somebody said, for making sure that you've got some data collection going on, and it means that quality improvement is actually measurable. I think that's an excellent bit of work in itself. So when you do implement a change, then you can show some impact. Certainly we've had a lot of trouble from highlighting medication events, but then not being able to show that the things we've done have had any impact, because most people don't cause harm. It's very hard to show because you don't reduce harm, and you're not going to stop people making human error kind of mistakes.
Yeah, I think that's right. And the other thing with if people rely on incident reporting, when incident reporting goes up, you don't know whether that's because you've got an increase in problems or whether people are just reporting more. And vice versa as well. If there aren't the reports there, is that because people have just stopped reporting, or has the problem gone away?
Yeah, certainly we found that were two things. One was when we moved from paper to electronic incident reporting, even though that was a few years ago, the reporting went down. And then when we used to be very good reporters of medication events, and then we have to start doing reports to say what we've done about it. So the thing people do about it is they stop reporting, because then you don't have to do anything about it. So that's, this is really good, as you said, as an independent, a bit more objective measure.
Brilliant. I want to leave time because I know sometimes there's a bit of delay on the phones. I mean, certainly something we're really interested in is thinking about whether this has relevance more widely than just at Birmingham's, because I think the problems, the problems that you're facing are the problems that we're all facing. And certainly one of the strengths of the other thermometers has been that, people have collaborated, and as you mentioned, there's a central portal and a central database, and these things can be looked at. But it is very difficult to find the kind of the funding and the place for that to live. I think it's a discussion that from the Meds IQ point of view, we'd like to continue to have and to support, because I think in time, once the more learning you have about your thermometer, then also the opportunity for other people to try out collecting other bits and, looking at it differently, and then sharing that learning would be really helpful. So I think we should keep the conversation going. Jane, I don't know I know you'd had some thoughts, if you're still there, Jane.
Yeah, no, I mean, I definitely think it would be something really worth sharing on a wider scale, and for the college to have input in, to be able to encourage all trusts ultimately to use the safety thermometer and for it to be useful for quality improvement. So I'm all in favour of supporting kind of onward plans, but as you say, still got to have a bit of a think about how that's best approached. But I don't know whether you've got any any sort of further progress to update on that side, Jeff? Or we can chat more about it later.
Yeah, I mean, the only thing I'd seen was the email from Jane Wee from NHS Improvement, and she was suggesting that, well, she was saying that the other safety thermometers, I think, are currently being supported by the Central Measurement Unit, a new body, I think, that's been set up. But they probably had other priorities at the moment, she felt, but if we could get it on the agenda at the local patient safety collaboratives, then they could perhaps get it on the agenda of the CMU. So that's something I suppose that was my next step, if you like.
Yeah.
I mean, I think the issue with funding is that what I didn't want to do was go through an application to just get a pot of money which might support the setup of something, because I think the setup is fine, but what there needs to be is some kind of ongoing support for it. So I think it would be terrible to set something up over a period of 6 months, for example, for people to report into, but then no kind of ongoing support for that ongoing data analysis and feeding back to the institutions that are then submitting the data. So I think there needs to be some kind of commitment from some body to have something ongoing, at least for a period of time, maybe a couple of years, to make it worthwhile to go through that setup process. And I think the other thing to say is that although obviously we've done this thermometer based on the information that what we feel is right, I'm also aware that that if we were to roll this out to other institutions, people might say, well, we're not really sure you've got the trigger of hypoglycemia right, or your anticoagulation triggers probably may not be set right, and that probably would be open for debate. So what we would probably need to do is a cycle of refining the tool based on input from people from around the country to get consensus on things like that before it was to kind of be launched nationally, if that's where it was going.
Steve, have you got any comments on that from a national perspective? Any of the bodies that you're part of?
It's sad to hear in some ways that it's gone so local. Say it was when the Child Health Safety Board became the paediatric patient safety expert group before NHS Improvement, then this was being discussed, and there was a lot of discussion about it actually at some of those meetings, and the whole remit then, and this was with Jane Wee, was that this would be a national tool. So it's quite sad to hear that it hasn't got that support anymore. I mean, there were a lot of discussions about what the triggers were and what that meant. Probably, hence my questions at the end of the talk in some ways. But I think, as everybody's been saying, in some ways, the fact that you can focus on and monitor yourself against certain triggers is probably better than what most people are doing. It doesn't necessarily mean you change anything in terms of your understanding, but at least you have a tool to understand how you're doing against certain parameters. And I think it's a bit of a shame, and I must admit virtually everything from the national front of NHS Improvement seems to have gone very local rather than national since it became NHS Improvement. And I do think it's a real shame, because I mean part of it is understanding how you're doing, but also there's a great value in some benchmarking data as well, so you can actually understand whether your interventions are working the same as somebody else's interventions, and therefore anything we can do to improve that, I think that the better.
I mean, interestingly, the other thing that Rhiannon was involved with was contacting other paediatric hospitals across the country to find out what they were doing with regards to medicines reconciliation. And interestingly, everybody seems to be in around the same place, really, in the level which it's being performed. So it's clearly not just a problem with us.
I totally agree. I think part of the issue with that is, of course, how everybody monitors their patients, and whether they're I know certainly in our own institution our numbers look bad, but we've realised that so many day cases, as they were, are in for just over 24 hours on the PIMS system, but not in reality on the ward. And there's all sorts of bits which skew people's data. But you're right. It still means that it gives you something against your own figures to look at. And if you make an intervention, are you improving? Understanding that the figures may be skewed in the first place, but at least an intervention will still be skewed to the same extent, and therefore you can see how things are moving on.
Brilliant, thanks, Steve.
Oliver, again, I just kind of ask a quick question. I was just wondering if there's something in between this only being done in one place and there having to be in a central data collection and data analysis and conclusion drawing body. And if just more people were using the same dashboard, once, as you say, once it is tweaked so it meets everybody's requirements, people could just collect the data in the same way. They'd have their own data for monitoring of quality improvement. You could benchmark against other people with similar levels of data collection and similar institutions, and it may be that that's the first step towards having a truly national system. We certainly talked about trying to do something like that around audit through the Quality Improvement Committee. So I just wonder if it might just be that interested people make a start on it before there is. I know what you're going to do properly will need funding and a proper time scale, but probably is some small steps we could be doing.
Yeah, I guess, I mean, we have a system called Vesper, which a lot of our in-house data is put onto that system, and I confess I'm not particularly knowledgeable on how kind of particular IT systems work, but whether other people use that, other institutions use that same system or not, I don't know. But you know, I think if we could get an electronic tool, data collection tool that could be used on a tablet, then I'm sure that, you know, institutions could build their own, you know, systems behind that tool could feed into. Or the other alternative would be for me to share the paper version of the tool, and then people build something locally for their own, you know, that's suitable for their own needs, really, based on that.
Because at least that's a starting point for the people, isn't it?
Absolutely. Is the have you got this shared through MedsIQ?
I haven't, but I can do.
I was just thinking, I mean, in a neat way of wrapping up, it seems to me that you know, the potential, if you were able to share this and submit it to MedsIQ, then that's exactly the kind of thing that, in the absence of, well, you know, where there doesn't happen to be a major national strategy to support something, at the very least then the information is there for people to look at and see, is this something we'd like to implement locally, and then they can contact you and see whether that's feasible. So it'd be brilliant if you could submit that, because that's exactly what we want to happen from these discussions. We know that whilst we'd love to be influencing at a national level, sometimes, exactly as Jane Wee said, the priorities are just elsewhere right now, and actually we may just have to do it ourselves for a bit. And certainly at one level we can continue to look into what the options are for spreading this nationally, but at least if the information is there for people to use, they can try it themselves.
Yeah, no
I'm aware of the time, and that we were very keen to stop promptly at 2 o'clock, partly just because we promised that to everyone, and I know everyone's days are very, very busy. We usually have a bit of an update and a summary about what's going on in MedsIQ, and I don't think we quite have time for that, but the most important thing to say is that if anybody is at the college conference at the end of the month, then there are plenty of QI activities and MedsIQ activities, and Kasia, I'm going to give you a couple of minutes to very quickly tell everyone about those.
Thank you, Alice. So most of the two medication safety sessions that we're going to have are both on Thursday, which I believe is the 25th of May. And we're going to have a personal practice session that will be led by Jane and Alice, in fact, which is at 8 a.m. and then it's repeated at lunchtime. And we're also going to have a seminar on the importance of networks and collaboratives in QI, where one of the case studies presented will be MedSIQ, and the other one is going to be Making It Safer Together, presented by Peter Mark Fortune. I think some of you, and Jeff, you definitely are involved in MIST as well. So I hope that you'll be there if you're at the conference to also contribute to it too. We're also going to have QI sessions on Wednesday and on Friday at 11:45. All three of these seminars are in fact at 11:45. And the Wednesday one will feature the best QI abstract submitted to the conference this year. And we're also going to have a keynote speaker, Dr. David Bogan from Ireland, presenting. And Friday will feature a seminar on the controversy around having national pews in England, and should we go for it or not. Presenters for both the pros of that approach and the challenges involved. So I would really like to invite you to all these sessions. You can find the details on the website, and we'll also publish information about them in the upcoming MedSIQ bulletin that's coming out at the end of this week. And if you can also help us spread the word to your colleagues who will be coming to the conference, that would also be great.
Brilliant. Thanks, Kasia. Yeah, so hopefully we'll be able to see some of you in person there. And if not, then at our next webinar. We haven't yet set the date for that, but we will keep you informed. Do let us know how you find these. We think they're brilliant, and we really think the level of conversation that we get in them is fantastic. And so do please continue to attend. Jeff, thank you so much for talking. It feels like we could have continued this discussion at length, but it would be fab if we could get this onto the MedSIQ website so that some of that discussion can continue.
Sure,
and I suspect many people might be in touch with you. But thank you so much for doing that.
Thank you.
And thank you and goodbye, everybody.
Thank you. Bye. Bye.
Thank you.